All right. Well, good morning, everybody, and welcome to the Eqip meeting. I did want to go over a couple things. First of all, and we'll mention this again later on for people who sign on late, but we are not going to have a meeting on April 15th, not because it's tax day, but because in lieu of that, what we are doing is MedKai is reaching out and coordinating meetings with specialty societies, particularly societies where we had a level of interest about possibly adding a code. So we do have scheduled two right now. The Eye Society and MedKai are jointly doing one to go through the ophthalmologic codes, and we also have one scheduled with the urologist, and we're working to get the Urology Society to sign on. I will send out the flyers separately to the group, if not today, early next week. And I would just encourage you to please, if in your systems or hospitals or practices or whatever setting you work with any of these specialties, to share the information. Everybody's invited. Sign up. We want you on there. We want you to learn about it. You'll hear a little more about this today as Jessica will present. We are not going to do one for ER because that is going in, and you'll see some slides on how ER is going to work. But we will do something as we get closer to the summer, just an educational piece on the ER, but that is definitely going into CMS. So we're not doing that. Part of this is to gauge interest and see if we want to have or do something in these spaces. And that's why we're focusing on these first. I would also say, if you're in a specialty where you're interested in having codes ahead, you have to tell us now so we can start to discuss it. Information and discussions are occurring with CMMI and CMS, and we are happy to set up these meetings. Will and Jessica can go through the Prometheus codes related to a certain specialty or a certain area, but the time is now. So having said that, I guess, so Jessica, do you want me to, is Will the next presenter, or are you the next presenter?
He is. Am I not seeing him on the list yet?
All right. Well, I have another thing I was going to share with everybody, so I'll go ahead and do that now. Maybe you can text Will and see what's going on. The other thing that MedKai and CRISP are working together on are learning materials around Eqip. And we're doing a series of educational, actually CME events that are going to be online. And the first is complete. The first is an overview of Eqip. It really kind of gives the 101. I think most people on this call probably do not need to see it, but where I think it can be very valuable for everyone on this call is that if you are working with a larger group of physicians in a system, or maybe you're a larger private practice and you want physicians to understand why they're doing what they're doing or why the change has occurred, this can be a very valuable tool for you to just kind of give them the Eqip 101. On top of that, it's been accredited for 1 credit of CME, and it's online, so you can do it on demand. So I will also be sending out links to that continuing medical education, maybe as early as today, but as late as next week. So I think we're going to have a lot of information coming out, and a lot of these informational calls over the next few weeks, and we're very willing and able to add more.
Okay, so hold on, let me.
Did you have a question, Barbara? No? Okay. So having said that, with regards to the educational materials, the other thing we will be doing is CRISP and MedKai are going to be working to build a complete learning center. I will also say this from a helpful point of view. As a result of the data breach, we have the CRISP website, or the Maryland website, the HSCRC website is a little bit behind, but the MedKai website has all the Eqip meetings up. So if you've missed any of them, you can watch the full recording of any of the Eqip meetings. So having said that, Jessica, has Will made it on yet? Okay, well then we will turn it over to Will and let him take over. Will?
Hi, Gene. Thank you. Sorry, I'm a little late.
Oh, that's all right.
Who's steering these slides?
Right now, Jessica is. But
Oh, wonderful. Wonderful, Jessica. Would you mind going to the next slide?
We'll kind of skip this agenda.
Sure. Okay,
and we set them out last night, Will, so everybody should have them.
Wonderful. So we wanted to do a couple things in this meeting. The first is talk about a brief overview of the Eqip program for anyone who's new on this call and has not been through the previous conversations. Eqip obviously is a complex program, and so if this brief overview does not cover it, please reach out to us, and we're happy to have offline conversations where we can walk through the program in detail. We're then going to talk about some new episodes that we're intending to add or considering adding to Eqip for year 2. There's some policy implications for those episodes that we want to talk about and get stakeholder perspective. So a very brief overview of Eqip. Eqip is a bundled payment program or an episode payment program where physicians are accountable for the costs that are included in those episodes. The intention is to incentivize physicians to manage the cost of care for those particular episodes a little bit better in order to produce savings and support the total cost of care waiver test that we have with CMS. There is upside only in this program, so there's no downside risk. If you're not successful after 2 years, we will kick you out. So there is some accountability. If you produce savings consistently, we will kick you out and you would potentially lose that macro qualification, but there's no direct downside risk based on the total cost of care. We've also partnered and worked with CareFirst in developing a similar approach to episode definitions. What I mean by that is both they and us use the Prometheus episodes to group episodes. We did this because we wanted to ensure that hospitals and physicians that are participating in this program only had a single definition of an episode that they are trying to focus on. I'm sorry, I'm getting a lot of feedback from folks on the line. So if you're not speaking, please mute yourself. Okay, thank you. I think that's a little bit better. So the intention of alignment with CareFirst is we want there to be a single definition of an episode so that if you're in 2 joint replacement episodes, one with CareFirst and one with Medicare, that you're only working with a single definition, that you don't have to define things differently based on the patient's insurance status. That being said, this Eqip part of the program is Medicare only. CareFirst runs its own program. There is no requirement that you participate in CareFirst program if you're in this program or vice versa. And there are different policy and financial design decisions that we've made. So our intention is to align the episode definitions as much as possible with other payers in the state, so that we don't drive physicians crazy on the ground with multiple definitions of the same thing, but otherwise these programs are separate. And lastly, this is an advanced alternative payment model, which has some benefits through the CMS program, and there's some bonus payments and higher fee schedule updates, et cetera. Next slide, please. So in year 1, I've listed the episodes that we've included. We focused on 3 specialty areas in order to get a significant number of participants from those areas in the Eqip program. But we are intending to add additional episodes over time and grow the program, both in terms of the number of episodes that we have and the specialties that they cover. Next slide, please. So if you're interested in more information, please reach out to either equip@crisphealth.org or MedChi, and we're happy to follow up and answer any questions that you may have. We're also happy to discuss any further opportunities for future episodes. So if you looked at the previous slide and you saw that it was missing an area that you'd be interested in participating, please reach out to us and we're happy to have a conversation about how we can add additional episodes to accommodate your interests. Next slide, please. So we've been talking to some specialty groups about adding additional episodes. I've listed the interested specialties and the episodes that we think correspond with those specialty groups here. Now, I want to emphasize that this is not restrictive. So in other words, we're not saying that only allergists could participate in an asthma episode. Any physician could trigger any episode. They have to provide the triggering service. And we just listed the correspondence here that we think is most likely to occur, but there could be internal medicine handling UTIs, for instance, and there's no physician specialty restriction on who can trigger which episodes. So we've had some additional specialty groups that are interested in participating, and we've listed the episodes that we think are applicable to those specialty groups here. Now, there are some different policy decisions that we'll need to make. So on the right-hand side of this table, we've listed some new episode types. There's now both procedural episodes, which we had in the past, and also chronic and complications episodes. And we're going to talk about what those different episode types mean for how we structure the program and the episodes. Next slide, please. We've also been talking with some ED physicians who proposed new definitions so non-Prometheus definitions for episodes that are triggered in the ED department. The ED physicians proposed episodes falling within these areas. And so we're working on including those for year 2 of the Eqip program. Next slide, please. So in total, this gives us 4 different types of episodes. The procedure-based episodes, these are triggered by a physician that performs one of the triggering procedures. These are all of the year 1 episodes are procedural, and then a couple of the proposed year 2 episodes are procedural. The emergency department episodes that have been proposed are a little bit different. Instead of triggering based on a procedure, they'll trigger on an ED visit that has one of the triggering diagnoses. And we're going to talk about the implications for that change in a couple slides. There are then also complications episodes. So these episodes are still triggered by a procedure, but they're also typically closely related with another episode. So they tend to occur frequently together. And that means that we have to consider the overlaps between those 2 episodes. And then fourth, there's chronic episodes. So these episodes, if you go back 1 slide, Jessica, are something like glaucoma, or maybe 2 slides, glaucoma or asthma. Some of these chronic episodes where there's not a clear triggering procedure that starts an episode and assigns its management to a particular physician. So we're going to need to come up with some alternative attribution rules for how we know who's managing which patient's lower back pain, for instance. And that change in the attribution algorithm will cause some differences in the program design and have some implications that we'll talk about later. Next slide. So to start with, procedural episode is pretty simple. If you're in an Eqip entity and you have a care partner, so a physician, and they perform one of the triggering procedures on a patient, they trigger an episode. And that physician is then responsible for care that occurs during the episode window. Now, one of the neat things about the Prometheus episode is that it only includes what is called related costs. So Change Health, who administers the Prometheus algorithm, has a bunch of very smart doctors look at all the codes and figure out which ones are clinically related to the episode and which ones are not. And this is a big distinction if any of you participate in Medicare's BPCIA program or other total cost of care programs. The federal government tends to include all costs that occur after a triggering procedure. So essentially saying, if you have a major joint replacement of a lower extremity, they'll include all costs that happen 30 days after that joint replacement. Whereas the change algorithm will say, we're only attributing costs that are related to a joint replacement. In some ways, I think the Prometheus episode is much better. It means that if your patient has a joint replacement and then has the misfortune of being in a car accident the next day, the costs related to the car accident wouldn't be included in the episode. And so it makes it a little bit more tightly related to the clinical episode. And then we compare the costs of the episode to a target price. And if the costs of the episode are lower than the target price, the provider earns some savings. And if they're higher than the target price, the provider doesn't earn any savings. But again, there's no downside risk. So there's no possibility of a provider paying back dollars to CMS if their costs exceed the target price. Next slide. So the ED episode is a little bit more complex because instead of triggering on a procedure, it triggers on a visit. And what that means is that if a visit occurs and triggers an ED episode, a Prometheus episode could very easily follow within the next 14 days, which is the length that was suggested for the ED episodes. And so we have to figure out some way of handling the overlaps between the ED episode and another Prometheus episode that occurs within the next 14 days. This is difficult because although unrelated costs will be excluded from the episode, some of those Prometheus episodes are actually going to be related to an ED visit. So for instance, we have Prometheus episodes for AMI, and we have a proposal from the docs to include an ED visit for chest pain. And I think it's very easy for a chest pain episode to result in an AMI episode. And so we have to figure out some way to handle that overlaps question. Next slide, please. So the reason in particular why it's problematic is that if we were to trigger two different episodes, the first problem is that two different physicians would be accountable for the same service or managing the same patient for the same period of time. And we don't want to create duplication of accountability because that will cause chaos. The second problem is that if one of the providers was successful in reducing the cost of care, since those episodes overlap, we would end up paying those savings to both providers, and we would end up double paying physicians for the same improvement in care. And that's problematic because we have to reduce total cost of care. With Medicare, we can't therefore double pay or pay extra for physicians or for the same improvement in an episode. We thought about a couple of ways of resolving this overlaps problem. We could just exclude the overlaps episode. The problem is that would limit the savings that an ED physician could potentially earn from those downstream episodes. And so we didn't necessarily want to do that. Instead, we came up with another option. If you go to the next slide, please, Jessica. Where in an ED episode, we're going to remove any costs associated with the downstream episode and replace those costs with the average target price of that episode. I'm going to go into a little bit more detail on the next slide, but I'm going to talk through it right here just to give an overview of why we're trying to do that. So we want to allow the ED episode to earn savings by preventing downstream episodes that occur. Once an episode does occur and the accountability for that episode is assigned to a different physician, we want to ensure that secondary physician gets savings that are created by better management of the secondary episode. And so the way we handle that is we will put in the average price of an episode into the ED episode. And that means that if the physician avoids the ED episode, they'll receive shared savings on the average cost of that episode. If they don't avoid it and that episode is triggered with the second physician, that physician then has the opportunity to earn shared savings by managing that episode well. And those savings are going to be paid only to the physician that's managing that secondary episode. The first physician will just put in the placeholder average cost of that episode because they're not the ones that are accountable for managing it. The downstream episode then runs as normal, and the cardiologist or whoever is managing that downstream episode receives the shared savings payments, not the ED physicians. So I'm gonna stop there. I'm not sure if I heard a question jumping on.
The average cost be the average cost for the state or the average cost for that particular healthcare system?
Yeah, so we're thinking it's going to be the average cost for the physician, the ED physician.
It's a Eqip. I just said, like,
Okay.
Hey, Will, this is Jesse here. So just to clarify that, so this will be the average cost for the physician, which is going to be the hospital average cost, right? So basically, it'll be at the site level.
Yeah, so it'll be at the, I think, and I should clarify, when I say physician, it should be at the Eqip entity level. So how we define that collection of MPIs, we really probably won't have enough data to do it at the individual physician level. So the Eqip entity level. Okay, next slide, Jessica. So I do see the chat. Can I walk through a clinical example of this? I mean, the answer is no, because I'm not a clinician, but I'm going to do my best attempt here using some of the Prometheus definitions. So we have here an ED episode begins with chest pain. So a patient visits the ED with chest pain. That triggers a 14-day episode. The ED physician is accountable for costs that are included in those 14 days, the related costs included in those 14 days. It's possible that within the next 14 days, an AMI episode will trigger, potentially with a different physician, so maybe with a cardiologist. What that means is we're going to allow the cardiologist to take over management of that patient because they've triggered an AMI episode. Now, we could just exclude those costs and say, you know, as soon as the cardiologist takes over, all of those costs are removed from the ED physician's episode. But the problem with that is that it would limit the ability of the ED physician to get savings by avoiding episodes. And so instead, we're going to put in the average cost of the AMI episode into the ED episode, so that that physician still has some accountability for avoiding those AMI episodes, but they don't get credit for improvement in those AMI episodes because that's attributed to the cardiologist.
Hey, can I just ask about that? So basically, someone has chest pain, they have an MI, and I mean, it's not that the ED. There's nothing the ED physician can do to avoid that the chest pain is caused by an MI. That's just the underlying pathophysiology of what's going on with the patient. I'm trying to understand the concept of avoiding that AMI episode.
Sure. So I guess and again, the reason why I said that I can't walk through a clinical example is I'm not a clinician here. So I'll defer to you guys on the clinical stuff. I guess the way that I would think about this in terms of the data and the structure of the program, if the ED physician manages the AMI without sending it over to somebody else who's a cardiologist, then they don't trigger the AMI episode. If they hand off that patient to a cardiologist, then we trigger a second AMI episode and attribute the improvement in that episode of care to the cardiologist instead of the ED physician. And so, I think this is really not how do you avoid it sort of clinically. If they come in with chest pain and they have an AMI, they have an AMI, there's nothing to do with that. This is just a question of who we attribute it to. And if that patient is handed off to a cardiologist instead of the ED physician, then we'll trigger an AMI episode with the cardiologist. If the ED physician is able to manage it, then we keep the episode with that ED physician. Does that make sense, Dr. Pines?
Yeah. So, but the average cost of an AMI episode is probably going to be significantly higher than a chest pain episode. So basically, the ED physician gets attributed the cost of the average cost of the AMI episode if their patients, with chest pain ultimately have an AMI. Let's say they someone comes in with chest pain, we don't determine immediately they have an AMI, and then 12 hours later they've got some blood tests that show they have an AMI or things change, then all those costs would be attributed to that sort of lower cost episode of chest pain to the physician, ED physician, right?
Yes.
I guess
Sorry.
Sorry, I'm confused by the levers of change in this program, because if a patient comes in with an AMI, you make it seem as if the ED physician could manage it without referring to a cardiologist, but that would be very difficult to do. It sounds like those episodes, if a patient comes in with chest pain and has an AMI, like there's really nothing the ED physician could have done. So there is no lever of change. It feels like that episode should be completely removed from the bundle, because the things you can do are the chest pains that are not AMI. A chest pain that's AMI is already something that the physician could not do to control, if that makes any sense.
Right. So there definitely could be instances where there's really nothing that the physician could do, and it progresses to a second episode. And so again, I think that this could be handling a case where, most of the chest pain with AMI is going to be attributed to a cardiologist and then get included in the average. We would include the average price in the ED bundle. If there really is like literally nothing that you can do, and 100% of the AMI episodes are attributed to a cardiologist, then we could just remove the AMI episodes. And that could be a better, solution. And we'd definitely appreciate your clinical advice there. If there's really zero overlaps and there's no way that an ED physician would be able to manage a AMI episode without turning it over to a cardiologist, then that's great information for us. And, we would remove that episode.
I would think it'd even be like malpractice if an ED physician was trying to treat an AMI. Like, I don't even know what they put a stent in the ED. There's really nothing an ED physician. If a patient comes in, like that has to go to a cardiologist.
Right. So that's very helpful advice. And I think if the answer, the consensus is clinically, all AMI cases will be handed over to a cardiologist, we'll just remove that episode. If you go back up, Jessica, a couple slides to the list of the ED episodes. Sorry, is there another comment?
Yeah, Will, this is Jim. I think where you may be going with this might be a bit better of a description, and to say that, yes, everybody's been correct here. And emergency physicians, there may be some acute intervention, but when it comes right down to it, acute MI is going to go to a cardiologist in some fashion. But maybe it's really about chest pain and how the emergency physicians are evaluating that and the downstream impact of what that may have. What we think initially may not be an acute MI, maybe we even think it's non-cardiac, gets sent home and ultimately has some intervention later on, or ultimately rules in, as I think Jesse had mentioned, would be a bit more of a descriptive way of going about this, because almost always when there is some sort of defined significant diagnosis requiring admission, that's going to get passed on to some sort of specialist or internist or surgical specialist. Just a thought out there.
Yep. So I think that's right. I think it's our intention to let the ED physicians manage anything that does not rise to the level of a handoff. If there is a handoff, we want to ensure that the cardiologist is responsible for it. Now, if there's literally no overlap between those, every single AMI is handed off to a cardiologist, then I think we should just exclude that AMI episode entirely, rather than doing this average cost approach. That being said, looking at these proposed episodes, there are definitely ones where I think an ED episode or ED doc probably could manage it without escalating it to the level of a handoff. Urinary tract infection, we're going to talk about that as adding a urology episode for urinary tract infection. And, Dr. Pines and others have proposed including UTI on the ED. And so this approach, I think, would apply there if the UTI can be handled in the ED and without rising to the level of an ED physician, a specialist, then great. if it does rise to the level of the specialist, we want to attribute the accountability to that specialist instead of the ED physician. And so the incentive there is to try and get the ED physicians to be able to manage that UTI case without rising to the level of needing a specialist. And so it may be that I just chose the wrong example here, and that the AMI really is severe enough that a cardiologist has to be called. But I think we would apply this approach to all episodes where there's some question about whether it needs to be elevated to a specialist or not. Does that make sense?
Hey, Will, it's William.
I will.
Just I think what you said at the end was what I was going to. I mean, I think we may have chosen a bad example. I think that we want this group to think about this as a conceptual question rather than a specific question, right? The conceptual question, as you said, is when we have these ED episodes and another type of episode is triggered, do we completely exclude that and the ED doc only worries about the stuff that is in theirs, or do we do that kind of substitution? And there may be some clinical situations where the substitution makes more sense and some situations where it doesn't. But we do ultimately also need a fairly simple rule. What we can't do is go through each one of these and make different decisions for each possible downstream episode. I'm not saying I don't think it has to be all or nothing, but I think we ultimately do need to have a fairly straightforward rule that says these downstream episodes are in and these are separated. But it is a conceptual rather than a practical question specific to AMI, as you said. The other point I would add is it's a relatively small overlap. It's not like every one of these ED episodes is going to kick off a Prometheus downstream episode. So we're really deciding what to do in the situations where they do.
And maybe one of the ways we could address that is the ED group could propose a couple of exclusions where that clinical linkage exists, where there's really nothing we can do, like the AMI example, and just have a couple of standard exemptions.
Yeah, so we're happy to consider standard exemptions. So if you want to propose those, we'd be happy to look at them. I will say that sort of the cost of not doing the exclusion is not very high, right? Because we're just putting in, we're putting in the average cost of both your target price and your performance price, and so they will wash out. And so I think clinically, if there really is nothing to be done, then we should include that in the exceptions. But if there's a borderline case, there's no real problem with including, I think, the average cost in both the target price and the performance price.
I mean,
Will,
yeah.
Oh, go ahead, Dr. Pines.
Yeah, I guess my concern again is the sort of the differential price targets for these episodes, which are going to probably be, could be 10 times less than the Prometheus episodes. If we start adding those into some of those, then things could get really really skewed.
So I think if you add them in both the target price and the performance price costs, I think they the level would increase, but there wouldn't be a skew. But I take your point. If there really is no clinical way to manage the episode, then we should exclude it from the ED episode entirely.
Okay, understood.
Go ahead, Gene.
So 2 points. One is maybe I will recant what I said earlier. We were talking about doing the ER group in the summer. Maybe we should do that meeting sooner. So if we need to make adjustments with CMMI or CMS and what we're presenting, that would be useful. So I'll work with Dr. Linton or Dr. Pines or one of the folks from the ER side to set that up. And then secondly, I see there's a question in the chat about the Care First program. So I'm not clear if the question is specific to ER or if it's general. Generally, my understanding is Care First has started doing their value-based payment with certain episodes. Will and Jessica and I were talking in prep for this meeting about inviting Care First maybe to come at one of the future meetings and give a little overview as part of the presentation about what they're doing. But obviously, they're a private entity. Well, I guess they're technically a nonprofit, but they're a private entity that controls their own stuff, and Will and Medkai and Chris don't really have any ability to know what they're doing. So I think it'd be best to hear directly from them, and we'll try to see if we can't coordinate that. You want to correct that in any way, Will?
No. I think that's good. I think our approach is an open application process, right? We don't have any really rigor. We don't choose who to invite to the program. I think Care First has their own process for enrolling people in the program that I think is a little bit more selective. But yeah, we should definitely include them as and share some of their program detail.
And let me say this, I mean, we're not excluding other carriers, and I don't know if we have any other carriers on, but I'll make a point of reaching out to the league. I mean, if they want to do value-based payment, we'd love to hear from them as well. I think it'd be great. One of the things that I've heard in a long time, I've worked for Medkai, is physicians complaining because these programs are different. You're dealing with different codes or different measures, and it can be complicated when you're switching from patient to patient based on what kind of insurance they have. So, commonality can be helpful. So one of the nice things about Care First is they're using Prometheus, and we are too, so that's helpful. But we'd love to hear from any of them, and we'll make the invite to everyone if they want to talk about what they're doing, and we can do that for a future Eqip meeting, and I'll put that on the list of things to coordinate. Okay.
Great, thanks, Gene. So as this conversation has indicated, we'd very much appreciate thoughts from stakeholders. To Dr. Pines, if you want to make suggestions about exclusions, et cetera. There's also a possibility that we don't need this approach if there really is very little overlap between the ED episodes and the Prometheus episodes that trigger. Then I think we wouldn't need to do this. So, for example, if the ED physicians treating chest pain are also responsible for the AMI, there'd be no need to separate those episodes, although this conversation suggests that actually probably we'd need to separate it entirely, and the AMI episodes go to cardiologists exclusively. Any last minute questions there? Okay. So complications episodes are the second type of new episode that we're considering to add. These episodes tend to occur coincidentally with another episode in the Prometheus algorithm. And that I think raises the same sort of overlaps issue that we talked about with the ED episodes. And so we're proposing, if you go to the next slide, basically to use the same solution from the ED episodes in the complications episodes. So in other words, a procedural episode triggers and there's a secondary downstream complications episode. We want to give the upstream provider the incentive and the rewards from avoiding the complication. But if the complication occurs and triggers an episode with another provider, we want to give that provider the incentive to manage that episode a little bit better. So if you go to the next slide, and hopefully I've given an example that's a little bit more clinically relevant, but again, not being a clinician, I really have no idea. So, we have gallbladder surgery as an episode, procedural episode. We also have we're proposing to add UTI as a complications episode. If those two occur within the same window, what we would like to do is give the physician that triggered the gallbladder surgery the incentive to avoid complications. And so give them a reward if they avoid triggering a UTI episode. On the other hand, if the UTI episode is triggered and is handed off to another physician, we would want to give that urologist or whatever physician is managing the UTI the incentive to manage that episode of care a little bit better. So again, we'll take the average cost of the UTI, put it into the gallbladder surgery episode. Basically, that means that if a complication is avoided, the provider gets the savings equal to the average cost of that UTI. And if a complication occurs, then their episode costs increase by the average cost of that UTI. But then the UTI physician who's accountable for managing that episode has an incentive to improve the cost of care within that UTI episode. Any questions there?
Yes. So are you going to build in a complications component into every episode?
No, so we're proposing only to, if you go back a couple slides, Jessica, a couple more back to the proposed episodes. So we're proposing to add in the complications episodes that are listed here. And so there definitely won't be a complications episode associated with every episode, but accidental falls, UTI, catheter associated UTI, et cetera, those would trigger episodes. And that we can consider adding in additional episodes, including additional complications episodes in future years. Does that make sense?
I'm a little bit confused though, because if you say like you have gallbladder, but you're going to give them credit for a UTI complication, you're going to put the average cost of the UTI included in the gallbladder episode. Are you going to put a falls complication in that rate as well? I mean, it's almost like, how do you decide what complication might be likely to occur with the episode, procedure episode?
Yeah, so it's a good question. So again, we're using the related cost. We're still using the related cost, right? So the gallbladder surgery, the related costs of that already include, catheter associated UTI, for instance. And so in the existing Prometheus episode, those costs are currently all attributed to the person that triggers the gallbladder surgery. Once we add the UTI episode, it's possible that another physician is then managing the UTI episode that's currently part of the gallbladder surgery episode. So that's where that overlaps problem exists. It's possible and in fact probable that in the related costs of the existing gallbladder surgery, some of those complications don't appear as related costs, in which case there's no overlaps and there would never be, this problem associated with it. So dermatitis, for instance, might not be a related cost to the original gallbladder surgery, and so would not trigger, this overlapping episode. And so I think we've already handled that in the related cost definition of the gallbladder surgery. Does that make sense?
I think I need to digest it some more, but thank you.
I would just add to what Will was saying there that, right, this scenario here only applies where we've got both a procedural or an acute episode and a complications episode that overlap, which is relatively, again, not the majority of them. The episodes where there isn't an overlap, they too just operate like two separate episodes. So like the dermatology complications, they probably don't overlap with any of our existing episodes, so they will just operate as episodes. And then the Prometheus logic includes flags that dictate when a complication episode. So we're just following the Prometheus logic in terms of knowing which complication episodes to trigger.
So this, if I can take this one step a little bit further. So the gallbladder episode will only get an additional cost for the UTI if they have a UTI following that episode.
Exactly. So
Okay.
if a UTI
Okay. So
complication
kind of the
episode,
trigger, the rate will only change if they have a complication following that treatment or procedure episode. Okay, that makes more sense to me.
Yep.
Okay.
Could you
I have a
Sorry.
question though. So in this particular example, and I realize we're going down a rabbit hole with specific examples, isn't a UTI already a complication that is included in the analysis of target price for procedures? I mean, it shows up on our list of potentially avoidable complications. So the cost of that is already in the gallbladder episode or the pacemaker episode or whatever episode was triggered to begin with.
Right.
But now we're going to add in additional cost of a UTI episode. Something doesn't seem to add up.
Yeah, so not quite. So what we're saying is that currently, you're right, the UTI complication is already part of a gallbladder episode. Our problem now is that if we want somebody, a urologist, to be able to trigger a UTI episode, we have to figure out some way of separating it from the original gallbladder surgery. So it's already included there. You know, if somebody else is going to take accountability for managing that UTI, we have to figure out some way of separating those two things. One of the ways that we could do it is just remove UTI from the gallbladder surgery episode entirely. The problem with this, so both from the baseline target price and from the performance period, and then if you did a gallbladder surgery, wouldn't have to worry about UTIs at all. The problem with that is that we think that the gallbladder surgeon might be able to manage the case in order to avoid a complication, the UTI. And we want to give them credit for avoiding unnecessary complications. So we're going to leave the gallbladder surgery episode alone. We're going to keep the UTI costs included there, but we're going to replace all of the UTI costs with the average cost for a UTI. And so what that means is that if the gallbladder surgeon avoids a UTI, they will get shared savings equal to the average price of a UTI episode. If they don't avoid the UTI, the average cost of the UTI is added to their performance period cost in lieu of whatever UTI costs actually occur. And the reason for that is those UTI costs that actually occur are attributed to the urologist and compared to the urologist's target price. So this is basically saying that that if there is a urology case or a UTI, the urologist will be responsible for managing the UTI and will be compared to the target price for the UTI. The gallbladder surgeon is only responsible for avoiding a UTI case from occurring. And if they are successful in avoiding the UTI from occurring, they get a shared savings payment equal to the average price of the UTI, not whatever actually occurs in the UTI episode, because the urologist could be doing a bunch of stuff to reduce the costs, and those savings should be paid to the urologist, not to the gallbladder surgeon. Does that make sense?
That makes more sense. It's kind of like we're making bundles and now we're splitting them apart. Just an observation.
So that's a good way of thinking about it. So right now we have a bundle, and what the UTI episode does is it creates a little sub bundle. And if we're going to separate out that sub bundle and give it to somebody else, we need to do something in the original bundle. And the way that we're going to do that is we're basically just going to take the target price of the sub bundle and keep that target price in the original bundle while letting somebody else deal with the little sub bundle.
Got it. Thanks, Will.
And I think there is a broader point there, right? In all bundling episodes, right? People pull off the easy stuff and they do things that clearly are episodes like knee replacements. And then you try and expand the program and you say, all right, now we got to get into other areas, and these other areas, they're a reason that they're not in the first tier. We don't want to just give up. Prometheus does have episodes for chronic and complications and so on. So, this is our attempt to make that work, but we recognize it's a little bit more of a hard lift than, the easily defined procedural episodes.
I have a question. Does the physician treat UTI complication has to participate in the program?
Yes, this only occurs if the UTI episode occurs with somebody participating in the program. If that UTI episode is not participating in the program, then we just keep it with the gallbladder surgeon and let them manage it.
Okay, thanks.
Okay, any other questions here? Okay, so the fourth type of episode that we're considering including are chronic episodes. And so if you think back to that table with the proposed year 2 episodes, there were things like glaucoma, lower back pain, et cetera, that we would like to include in the program as well. Now, these are a little bit difficult because there's no clear procedural trigger where a physician becomes accountable for lower back pain. If there was, we would just use that as the trigger for the episode itself. And we wouldn't, we could just treat them like any other procedural episode. But I think we and Change's clinical experts couldn't come up with any clear procedural trigger to say, now this specialist is accountable for the lower back pain. So that means we have to develop alternative attribution rules. And we came up with 2 potential alternative attribution rules. One, we could attribute the chronic episode to the physician that provides the plurality of the related E&M claims, or we could attribute the chronic episode to the physician with the highest E&M related costs. So in other words, if you're seeing a lower back pain patient, we'll attribute that patient to you if you provide the plurality of the care related to that lower back pain episode, or provide the most costly care for that patient. The problem with this is, if you go to the next slide, the problem with this is that you won't know whether that patient is actually attributed to you until after the episode duration. And so if lower back pain episodes are going to be attributed to the patient, to the physician that provides the plurality of the lower back pain care during that episode, you obviously won't know who has done that until the end of the episode. Now, you know, as a matter of program design, I think it is better to have patients attributed to physicians when they see that physician, so that the physician can know this person is either in or out of the episode. However, with these chronic episodes, we don't see a way of doing this. And as a result, this will mean that physicians that participate in those lower back pain episodes, those other chronic episodes, won't know who's attributed to them until the end of that episode. Ideally, we would be able to find some way to attribute patients to physicians. You know, there's a single service that means you're responsible for lower back pain. But absent finding one, I think this is the second best alternative that we have. So we very much appreciate stakeholders' perspective on which of these 2 attribution algorithms is better and would be preferable. And then we'll make a decision based on whether to include those if enough people are comfortable with that level of uncertainty to choose to participate in the episode. And so, you know, please let us know if you're interested in participating. We're happy to include these episodes. You know, if there's too much uncertainty and physicians are not, you know, comfortable with that, then we won't include those episodes. So I'm gonna stop there, see if there are any questions. Okay. Hearing none, if we could go on to the next slide. And one more. So this is just a quick reminder about how this program works for those people who are new and interested in participating in those new episodes. Once you choose to participate in those episodes, we're going to look at the baseline period costs and create a target price for those episodes. That target price is basically how expensive those baseline period costs were times inflation. So for example, if your UTI costs, you know, $4,000 in the baseline period, and with inflation, it's now $6,000, that's your target price for a UTI episode. We then compare your actual costs in the performance period to that target price and pay you shared savings based on the difference between the target price and the performance period costs. The amount of the shared savings included here varies. So if you're very expensive, we're going to pay you a lower share of the savings because we need to get those episodes closer to the statewide average. If you're very efficient, we're going to pay you a higher share of the savings because it's harder to improve an already efficient system. We also will do a small adjustment for clinical quality. We'll withhold 5% of the incentive payment, and then a provider can earn that back based on their quality performance. So an improvement in the quality will allow you to earn that 5% of the incentive payment back. It's a relatively small amount, but I think important to include a quality component to our programs. There is a limit on the amount of incentive payments that we're allowed to pay. CMS prefers that we don't make any payments in excess of 25% of the Eqip participants' Part B annual payments. And that's to make sure that the fee schedule itself is sort of the controlling incentive for providers. I don't anticipate this ever coming up. And then the final incentive payment is based on the shared savings tier, your performance, and the clinical quality score, and we'll pay it in full after the end of the performance period. Next slide, please. So as mentioned, we will create a target price. We're pretty sure, I think at this point, that we want to use 2019 as the baseline for new episodes that are added into the performance period for year 2. The reason for that is, COVID had significant effects on volumes and acuity, and potentially will disrupt the accuracy of those target prices. If we were to, say, compare your COVID period to a non-COVID period, that comparison is potentially not accurate. So we want to stick with 2019. We are still considering the possibility of using a baseline period. So if you really have thoughts and you think 2020 or 2021 is comparable, feel free to speak up and let us know. But I think our intention right now is to use the 2019 period as the baseline period. And then just a reminder that each Eqip entity has a singular target price. So one of the unique things that we do in this program is we compare you only to your past performance. This is distinct from other bundled payment or episode payment programs where you're compared to statewide average, something like that. We will compare you to yourself, but we need to have sufficient data to be able to make that comparison. And in general, a single physician is less likely to meet the data thresholds. A single physician could be their own Eqip entity, but in general, we allow physicians to package themselves together, and that we set a single target price that's the average of all of the physicians that are participating in the Eqip entity. So if you have one physician, then it's just their target price from the previous period. If you have 10, there's a single target price for all 10 physicians. Each Eqip entity must have at least, not at least 50 episodes total, and 11 episodes in each episode category they choose to participate in. And again, that's so that we have enough data to construct a accurate target price. Next slide,
Will,
please. Yep.
I was just going to add one thing. I think it's important there. As Will said, you can combine physicians into an Eqip entity. You can also split physicians up, right? We don't have a rule that every physician in a group has to be the same Eqip entity. You just have to meet those minimums. So where I think this is important is if you have a group where, one part of the group practices in Baltimore at Hopkins, and the second part of the group practices in Howard County at Howard County General, they're going to have very different experiences, and that blending them can potentially put you in a position where you can't really accurately measure either of them. So as long as you can meet those minimums, your solution there potentially would be to do 2 Eqip entities, one for your Howard County physicians and one for your Baltimore physicians.
Thank you, William. Next slide, please. So, and sorry, before we move on, any questions on the quick methodology overview? If they're really detailed questions, we're happy to follow up with you offline, but I did want to give a chance for any overview questions. Okay, very good. In that case, we did want to talk very briefly about the availability of performance period data over the next year or so. So Eqip episodes have already started on January 1st. The program began and episodes began to be attributed for providers. Our intention is to provide data as soon as we can to you. That being said, as soon as we can is limited by a couple of things. So we need episodes to be finished, which means that however long they are has run out. And so we know, the episode window has passed. And then secondly, they must be completed in terms of their claims completion. And so the claims completion means that we need about 90 days after the end of the episode for all of the claims for services provided during the episode to trickle in. And so that means that our episodes are considered final 90 days after the end of the post-trigger window. So for a 14-day episode, this episode is completed about 104 days after it is triggered. A 30-day episode, 120 days after it is triggered, 90-day episode, 180, so on and so forth. So the reason why I'm mentioning this right now is that while our episodes began in January, looking out 140 days, we still don't have any completed episodes for January right now. And so while we will provide data to you as soon as we can, that soon as we can is limited by this claims run out. And if you go to the next slide, what we've done here is we've indicated our data release cycles and the data that will be available in those cycles. So in April of 22, next month, we will have data from CMS through March. That's not enough to run out any of our episodes. In July, we will have enough to run out a couple of our episodes. So in particular, our 14-day episodes will have 90 days worth of claims run out, but we'll only have 90 days worth of claims run out on about the first half of January. Our 30-day claims run out, we will technically have 30 days worth of claims run out, but only for episodes that were initiated on January 1st of 2022. So literally one day of data. In October, we'll start getting in substantially more data. So we will have, slightly more than the first quarter's worth of 14-day episodes and about the first quarter's worth of 30-day episodes. Our 90-day episodes will start trickling in October, but we'll only have about 1 month worth of 90-day episodes in October. By January, we'll have substantially more, and then throughout 2023, that data will trickle in. So we're providing the schedule to you so that you'll know when you can expect to start seeing performance data in the CRISP portal and start getting a sense of how you are doing. Obviously, we would like this data to be provided to you as soon as we get it. And, we think we are doing it here, but unfortunately, there's going to be some delay just because we need to wait for episodes to run out and for claims to run out. I'm going to stop here, see if there are any questions on this schedule. Is raw claims data available sooner? No. And I think also, we sort of go back and forth in our different programs. We used to provide data in ECIP, for instance, every 6 months. And the response from providers was that wasn't frequent enough. So we started a new program with CTI where we provide data even on incomplete episodes. And I think people have started over interpreting those episodes, and so people will freak out. Why are my costs so low or so high based on incomplete episode data? And so I think our intention here is to provide only complete data. If there really is a use case for the raw claims, please let us know, and we would be happy to consider revising that policy. But I think for right now, our intention is to provide complete episodes only.
So each report will have a cumulative view of the year, or will you send different reports based on new information?
So each, and Nate Hedberg, I think, is on here, but I think the change portal provides a cumulative view of the performance period.
So each time we get a report in July, October, January, it'll have, it will be reflective of that entire group of completed episodes.
Yes,
Gotcha.
Correct.
Thank you.
Yep. And so that's important to note, like, and again, I think this will be unavoidable, but on July of 22, somebody is going to call us and say, why do I only have one episode for January 1st of, or, included in 22, I've done, X number of pelvic fractures, and it's going to be because as of right now, we only have 1 day's worth of completed data. The next cycle will be showing you data from January 1st through March 30th, et cetera. So we did get a question in the chat. Will claims data that comes in after 90 days still be included in the expense? And let me explain what I mean by claims runout. So claims that occur within 14 days of a colonoscopy are included in the colonoscopy episode. The providers send in those claims with some lag, right? So you don't send in your claims like literally the second that the procedure occurs. And so those claims will trickle in over the next month. We are only including costs for services that occurred within 14 days of the triggering condition. And then we are waiting 90 days for those claims to trickle in. Claims that trickle in after 90 days will be cut off. Our analysis suggests that we're going to be getting 99% of the costs within 90 days or thereabouts. So almost all the costs will be included at that point, but there are going to be some costs that come in 180 days if there's some issue with CMS processing or something, and there we're just not able to include those if we wanted to provide data to you guys with any sort of timeliness. Okay, any other questions? Okay. So there are some implications of the data availability. Participants are going to be expected to submit an application to participate in Eqip for year 2 by the end of August. And there's going to be relatively limited amount of data available by the end of August. So a participant that's choosing whether to drop or add a new episode will have little data on their existing performance in August to make that decision. That timeline, I think, is unfortunate, but is driven by factors outside of our control. So CMS's vetting determines how quickly we're able to, or how when that application window has to close, and we can't push that back until there were more data, unfortunately. So we are reminding folks that participants that have not been vetted by CMS can't join Eqip. So potential participants, if you missed that August date, you're unable to participate in Eqip for the upcoming year. That being said, people who choose to submit an application in August and then are vetted by CMS will be allowed to drop until the start of the next performance year. So in other words, our recommendation to you if you're interested in participating in Eqip, would be to adhere to that August deadline, even if you don't have a lot of information, and then make a decision on whether to drop or not after you've been vetted by CMS based on data that is provided later on in the year, prior to the start of the next performance period.
If a new physician joins the practice or has joined the practice, and they weren't vetted before to have sufficient volume, we would be able to add them to the new application, correct?
Yes, you have, but you do have to add them to the new application,
Right.
and they will need to go through the vetting. Yep.
Okay, thank you.
And Will, this probably would be a good time to mention that one of the other qualifications is that 75% of all of the NPIs in an entity must touch a claim in the baseline period. So that new provider is a good example where they wouldn't have any claims in 2019, but they can still participate as long as the group as a whole has 75% participation threshold.
Yep. Thank you, Jessica. If there are no more questions, we can move on to the next slide, which I think is just to say, or maybe 2 more slides, to say that our next steps are going to be a subgroup meeting on May 20th, where we're going to finalize the available Eqip episodes for year 2. And that if you have any questions in the interim, please reach out to equip@crisphealth.org. And additionally, that participants that want to develop their own non-Prometheus episodes for year 3 really should start having that conversation with us now. We want to, including additional Prometheus episodes is not difficult because we have the wonderful resources of Change who've been working on this for a long time. If you want to add episodes, as we've tried to do with the ED episodes, we really need to start now because there's a lot more analytic work that goes into that. So please let us know and don't leave it until February of next year, in which case it probably will be too late for us to do the work and add those episodes.
And can we also just reiterate that I will send out the info on the urology meeting to talk about those specific codes, and the ophthalmology meeting, which we have scheduled, and I'll send that out and we'll encourage you to share them. And obviously Will and Jessica and I will be now maybe moving up that ER meeting just so we can make sure that we tighten that up. But again, if there's anybody who would like a specific call where we really dig into the Prometheus codes around that specialty, ask us now so we can get it on the books. It really is the 3 of us doing these. So the sooner you ask, the better. We have limited bandwidth. So we really want to make sure that nobody misses out who wants to participate in this.
Okay. Well, in that case, I think that was our agenda. So we'll let you all get back to your patients or your happy hour or whatever you have for this Friday afternoon, Friday morning. Oh my goodness. You can tell where my head is at. Have a good one.
A couple of questions.
Thank you very much.
Okay.
Yeah, thank you very much, everyone. Appreciate it.
Thank you.
What was that? Someone said they had a question. Go ahead.
Yes, this is Daniel. Yeah, I have 2 questions that I came across talking with a physician. One was that we're looking at our baseline data, and then we really like the sequence of the care report. Unfortunately, we think there might be a glitch there because we didn't see a lot of the inpatient rehab hospitalization, even though when I go to or inpatient rehabilitation, when I go to the raw data, there is plenty of those. So I was just trying to figure out, is the sequence of care, do you know if there's a known glitch to that where the inpatient rehabilitation is not correctly being populated? Then the second question is for potentially avoidable episode complications, is there any way for us to get more granular data on who the patients are for those episodes? And then the reason for that is the provider specific ask whether those are more likely due to elective cases versus emergency cases. he's a surgeon, so he's just wondering, those avoidable complications are occurring more on those more emergency cases. But I just have no way to drill it down to the patient level to answer his question.
So it's a good question. Regarding the first one, I'm not aware of any glitches, but if there are glitches, please let us know. So if you could maybe, I don't know, take a screenshot and point out where you're seeing that and send it to us, we'll be able to look into it and get you an answer. Then regarding the second question, we do make some level of claims available through the DEX program. We're happy to do a walkthrough of that, and that will include the PHI, and so you should be able to see, patients that are which patients are included there.
Yeah, so I have the access to DEX, and then I did download it. I just couldn't see. I don't think I saw any file that had it specifically labeled that, but maybe I missed one of the columns and it's in the files. But yeah, I can schedule a session with you.
Yeah, so
That's
why
okay.
don't you follow up and we'll do a walkthrough there.
Okay, thanks, Will. Appreciate it.
Anyone else? All right, well, everybody enjoy your weekend. Am I safe to end, Jessica? All right, Jessica said I could end, so bye, everybody.
Thanks, everybody.
Bye.